Well, we've heard a little bit about the who, we've heard a little bit about the how, and now or a little bit about the what, and now we'll hear a little bit about the how the program is financed and how Medi-Cal, or how plans get paid. We're very fortunate to have Lindy Harrington from the department with us and Scott Graves from the Cal Budget Center. Please join me in welcoming Lindy and Scott to the stage.
Thank you. So we have talked about all what I consider wonderful things that we do at the department through Medi-Cal. But we have to talk about how we're able to do that. And how we're able to do that is really how do you pay for all of these things that we're doing, and really looking at the limited resources that we have as a state, and how do you come up and really maximize those dollars and making sure you're getting the biggest bang for your buck. And I think, the first thing that we really need to look at is Medi-Cal financing and how it's developed. When you start thinking about Medi-Cal financing, we pay for the services that we provide. It sounds simple, but it's really not. When you start talking Medi-Cal, everything is complex. There's the size, the just breadth of what we do. And so when you start thinking about it, it really is a level of complexity that creates additional challenges when we start talking about how do we provide these services, how do we do all of these great things, but how do we pay for it, and how do we come up with those dollars to actually do that? So we in California have over the years created additional financing mechanisms that have allowed us to bring in additional federal dollars, but those additional federal dollars come with additional strings, and the ways we've come up with the ability to draw down those additional dollars creates, again, additional complexity. So when we start looking at what we have, we're spending about $99 billion on this program out of the Department of Healthcare Services budget for the 1920 budget year. That's what we're proposing to spend. The one thing I do want to really bring your attention to is, again, this is only the dollars that are in the Department of Healthcare Services budget, and as we move through this presentation, I'll tell you a little bit more about some of those other sources and where those reside. And so the $99 billion is kind of the low point of dollars that the state is spending on these services. So first we have to talk about how do we get those dollars, and where does that funding come from? Well, really, when you're looking at it, about 63% of the funding is coming from the federal government, which means the federal government gets a say in how we do what we do. And JC in the previous panels had talked a little bit about the various waivers and the programs that we put together. And those are all the approvals that we get from the federal government around what services we will provide. But that comes along with those dollars to provide those services. About 21% of our budget comes directly from the general fund, and the remaining 16% comes from other state and local funding sources. And so it's really those other state and local funding sources that bring in and are some of those creative financing mechanisms that we have done throughout the years. But again, the word of the day is complexity, and that's really what those dollars have brought to the program. As you start thinking through what do we want to do and how do we want to do that, you have to be thinking about where do those dollars come from and what strings were attached with those various dollars. So coming in, the federal government provides through the Centers for Medicare and Medicaid Services, also known as CMS. Most of you in the room are probably fairly familiar with that entity. And they fund a share of the cost at varying matching rates depending on the eligibility category or the type of service that is being provided. The standard matching rate for California is 50%. That standard kind of base matching rate will change depending on the state that you're in, based on a formula that CMS has created that has been in statute pretty much since the beginning of time, and it looks at the various poverty rates and uninsured and all of those things that happen in the state. We in California, being the size that we are at the bare minimum federal rate of 50%. There are other states that receive reimbursement at 75%, at 80%. So we again are having to fund 50% of the program. And so when you start thinking about the size of our program and being able to do that, When you look at that, being able to bring all of that in just directly from the general fund can be difficult. And so in order to do additional things, we have looked to additional funding sources. And so for the non-federal share of the Medi-Cal program, we actually have multiple funding sources. So we have the general fund, we have special funds, which are generally going to be taxes and fees that are specifically called out for those, as well as local government funds, and those local government funds are coming via intergovernmental transfers and certified public expenditures, and we'll talk a little bit more about those. So when we're looking at all of these other fund sources and where do they go and how do we use them, we're really looking at what is the dollar that's coming in for that non-federal share. When we start talking about those matching funds that are coming from provider fees, generally those provider fees are going to have been put in statute, and the statute is going to define what you can use those dollars for. So when we look at the total available budget and we start talking about, oh, we have all of these funds, let's think about everything we can do with those funds, we have to take into consideration that there's a portion of those funds that are very clearly earmarked by statute for what they can be spent on. For example, we bring in approximately, for every hospital quality assurance fee program period, we bring in approximately $10 billion worth of fee money that comes into the state of California. And everything's great. We can spend that money on the Medi-Cal program, but it's very specifically defined what we can spend those dollars on. We can spend those dollars on offsetting general fund costs for children's coverage, and we can spend those dollars on increasing rates to hospitals. Those are the two things that we can spend those dollars on. And so when you look at the overall budget, there are limitations to what we can do with those dollars. And that's an important thing to think about as you start thinking through the Medi-Cal program and how we can make changes and what we can do when we're thinking through of all of the possibilities. The other major funding source that we look at is we have funds that come from local governments. So you've heard about, standing up here talking about the specialty mental health services and the SMI and those dollars and the fact that the counties are providing those services. One of the reasons the counties are providing those services is because of realignment and the fact that those dollars are county dollars that are being spent on those activities. And so because of that, the counties have a pretty big say in how we, come up with those programs and what we do. Another area where the counties are providing significant funding is around the designated public hospital systems. And they are, when you look at the 1115 waiver, and all of those great programs that JC, talked about, when we look at the PRIME program or the GPP program, the Global Payment Program, the public hospital systems are actually providing the non-federal share associated with those various programs. And so, again, it's a limited activity source of where those dollars can be spent. And so when we look at that total $99 billion budget, and you look at 63% of those dollars are coming from the federal government, and they've laid out very specifically what we can spend those dollars on. You have 21% coming from the general fund. With the general fund, we have a bit more flexibility about how we can choose to spend those dollars. And then the remaining 16% are pretty much coming from direct special funds or local government funds or things that have very specific call-outs for how we can spend those dollars. And so that's a very important factor as you think through what are the next phases of Medi-Cal and what we can or cannot do. So really, when you start looking at how do we come up with that $99 billion estimate, we say we're going to spend $99 billion. How do we come up with that? And really, that is because we at the department do twice a year develop our Medi-Cal estimate. It's called the November and the May estimates. The November estimate is kind of a misnomer because it does not come out in November. It comes out in January along with the governor's budget, which I've always found kind of interesting because everyone's the November estimate. Well, it comes out in January. But it's really based on data and associated with November, so it's kind of the timing of when it's all put together. And then we also do an update to that November estimate in May. And so as part of the governor's May revise, we will issue an updated estimate that shows kind of what we anticipate our costs will be. It sounds simple enough. Look at, develop the costs associated with the program and put it out. Has anyone in this room actually ever seen a physical hard copy of a November or May estimate? There's a few people here. It is over 1,000 pages. And it is the result of approximately 1,600 regressions that are completed, as well as approximately 400 different policy changes where someone has manually gone in and adjusted assumptions and looked at costs and looked at how are we operationalizing all of the various aspects of the program. So what seems like, oh, we put out our cost estimate, seems easy. It takes approximately 6 months to do each one of those estimates, and that is a pretty tall order in order to get that all done. There are multiple areas within the department that are working on that. But really that estimate breaks out our costs into really 3 components. So you have the benefit component, so really looking at the cost of the services provided or the benefits going to beneficiaries. And that's really where the largest chunk of the dollars are going to be located is in that benefits category. We also have a section related to county administration and other administration, and that's really looking at the cost for counties to do eligibility as well as our ability to administer the program. And so that is another large expenditure area. And then the final area that you'll see in the Medi-Cal estimate is really the fiscal intermediary. And those are the costs associated with the claims processing and the systems to go along with that claims processing system. So along with the Medi-Cal estimate each year when we put that out, when we go forward with the governor's budget, at the time of the governor's budget, you will also generally find that we will have submitted budget change proposals to accompany the overall budget package. And really what you're going to find in a budget change proposal associated with Medi-Cal is really the services and the costs and the resources for the department staff and to be able to actually operationalize all of the great ideas or the work that we are doing. So in order to get additional resources into the department, we have to provide that budget change proposal. That budget change proposal, as well as the overall budget package, the Medi-Cal estimate, any trailer bill, or anything that we have put forward in order to take that next step forward or have the appropriate resources, are presented each year to the Health and Human Services subcommittees in both houses. And we will go and, as a department, have to support all of those estimates that we have put forward. And really that, in fact, my director as well as my chief deputies are going over this afternoon and presenting at the first budget hearing subcommittee for the assembly this afternoon to really support the proposals that we have put forward. Now, as many of you may or may not know, the budget must pass both houses by June 15th. And the governor will sign that budget along with the trailer bills. The trailer bills are really the legislation that will change statute that allows us to implement what they approved in the overall budget. And what is interesting about this is that statutory requirement for June 15th has been the statutory requirement, the constitutional requirement, for a significant period of time. And yet, it was only when there was a legislation passed that made it so that the legislative members did not get paid if the budget was not completed by June 15th, that we actually started getting the budgets completed and on the governor's desk by June 15th. Surprise, isn't it? Which has made life a little bit easier for those of us that actually have to operationalize these budgets, because when you look at developing a program and implementing all of those activities, when you don't know what's coming, it makes it a little bit difficult to determine how are you going to pay for those things. So speeding up a little bit and getting over all this, so when we look at program changes and legislative mandates that require mid-year program adjustments, we do those via the Medi-Cal estimate, and we work through those with the legislature, and then we notify our managed care plans as well as our fee-for-service providers of those changes via either all plan letters or provider bulletins. And when you start thinking about how does this budget impact, a hospital provider or a physician or a skilled nursing facility, and really how that translates through is that when you look at the dollars that we spend, we will provide funding to our managed care plans to pay their providers, and so they then will negotiate their own payment rates with doctors and hospitals and skilled nursing facilities based on the funding that we have provided to them. As well as those providers that are in the fee-for-service program, we will set our rates based on the funding that we have available, and they're paid according to the state fee schedule. So really, when we make decisions about what we will or will not fund, we are going to be impacting directly the funds that will ultimately roll into the overall healthcare system. So one of the things that really drives this is how do we set rates for our Medi-Cal managed care plans? And really, we have to set actuarially sound rates, and that sounds like a kind of a big statement of what we do. But really, we're looking to set rates that allow for the managed care plans to be able to provide those services and have enough funding to provide those services. So we set the rates that are reasonable and attainable for them to be able to provide those services. And really what we do is we're looking to provide the health plans a monthly capitation payment, also referred to as a PMPM. And these PMPMs are, again, governed by the rate setting. But really, we're looking at the health plan's own historical and adjusted base data. So we're looking, what did they actually spend their costs on? What was their own utilization? We're making adjustments for trend factors. We're accounting for any program changes. So if we added a new benefit or we took a benefit away, we're accounting for that in the rates. We're making efficiency adjustments. So if we're looking at how health plans spent their dollars, we're making some efficiency adjustments to, again, make sure that we're getting the biggest bang for our buck for those dollars. And then we're also adding a non-medical load to those funds. So again, for administrative activities, for underwriting, cost of UMQA and all of those things. And then we're setting that's their future rate. There are some changes to where we're not just using their own base data and setting an individual rate on a per member per month. And really we're doing that in areas where we have costs that are going to be unpredictable, or they're not an easily trended cost factor. And so really for those, we provide managed care plans with what we call supplemental capitations, also sometimes known as, you'll hear, kick payments for the health plans. And really those are going to be for where we aren't able to identify those costs immediately. So you're looking at maternity supplemental capitation. We did it when we had new benefits or high cost benefits. So hepatitis C drugs was a good example. As the cost for hepatitis C drugs with all those new drugs came out, we created a statewide supplemental capitation for the health plans in order to ensure that we were able to best match payment to risk for the health plans. So really quickly going to blow through these last kind of components. So really looking at how we spend the dollars by service category. So of our overall budget, 50% is going to managed care, and that 50% going to managed care really encompasses all of these other categories. So 16% on hospital fee-for-service, 8% on professional, 10% on other. But really, most importantly, as you start looking at how we're spending overall average per beneficiary, but most importantly, we're looking at the cost categories of the beneficiaries. So if you start looking, when you look at, we have 9% of our beneficiaries are seniors, are people with disabilities, and yet they account for 31% of our overall spend. And again, when you look at 7% of our beneficiaries are seniors, yet they represent 19% of our overall spend. But then you look on the opposite side of the spectrum, you have 35% of our beneficiaries are what we call the families category, and yet they are only 16% of our overall spend. So this is another area as you start looking at how do you focus and what changes are you making, you need to be accounting for these differences in cost. And with that, I will wrap up.
Thank you very much, Lindy.
What I want to do this afternoon, I guess, is to provide a little more context for the great overview that Lindy just provided. There's going to be a looking back portion of what I'm going to say, and there's going to be a looking forward portion. And in both cases, it's organized around how Medi-Cal is actually financed, sort of using that baseline that Lindy was talking about, which we all look at, the Department of Healthcare Services budget, recognizing that there are other Medi-Cal expenditures in other parts of the state budget. Oh, and before I start, I wanted to ask, show of hands, how many people, when Lindy mentioned the 1,000-page November 2018 Medi-Cal estimate, went to the DHCS website and looked it up right away and started? Anybody? I thought I saw a couple people. Okay, I think one, we got one or two. Okay, you actually, anyone who's interested at all in Medi-Cal, and I assume you are because you're here, should be familiar with those estimates, the so-called November and May estimates for Medi-Cal. You're never going to read all 1,000 pages. Just go to the management summary at the outset, look at the caseload summary, and you're going to learn a lot of things that you never knew before about Medi-Cal, and including some things that may not be coming up here today. So just in terms of the looking back portion of what I wanted to say, what we have in Medi-Cal here, DHCS budget, about $100 billion, so $99 billion, right? Lindy used the phrase creative financing. She also talked about the state's effort to try to limit the general fund impact of the Medi-Cal program. So the way that we know this is working is by looking back historically. So there are lots of ways to do this, but all I did is I went back to the last normal year we may have had in California before Lehman Brothers went bankrupt, triggering the financial crisis, triggering the Great Recession, triggering a horrible drop in revenues, triggering the American Reinvestment and Recovery Act, leading to the Affordable Care Act and the expansion of Medi-Cal. We've seen a lot of changes across Medi-Cal and state services over the last decade or so. If you go back before that to the 2007-8 state fiscal year, right? So that was kind of a normal year. We were sort of worried about a housing crisis, but we weren't yet in the depths of a recession. People thought we were going to fall into one, but we weren't in one yet. How much were we spending on Medi-Cal in 2007-8, 11 years ago, when you adjust for inflation? $46 billion adjusted for inflation. And how much are we spending today? $99 billion. So that is an increase of $53 billion that we are spending in total funds through the Department of Healthcare Services on the Medi-Cal program. That is a 114% increase over that roughly decade-long period. How many more people are enrolled in Medi-Cal? Well, 11 years ago, there were about 6.6 million Californians enrolled in Medi-Cal. You've already heard the number estimated for this year, 13.2 million. That's an increase of around 6.5 million. Basically, you can say enrollment doubled. So in the last 11 years, Medi-Cal enrollment has doubled. Total spending on the program has more than doubled. What has happened with general fund spending on Medi-Cal during that 11-year period? General fund is just basically sort of like California's checking account. Those dollars can be spent for any purpose that the legislature want to allocate those dollars for. So how much has general fund spending gone up over that period? 17%. When you adjust for inflation, we are only spending $3 billion more today out of our general fund on Medi-Cal, this Department of Healthcare Services portion, than we were spending 11 years ago. Okay, but I already told you the total increase was $53 billion. So wait a minute, $53 billion increase, $3 billion is from the general fund. Where in the world does the other $50 billion come from? Creative financing and much more generous cost sharing from the federal government, right? So just a couple of examples, right? With the expansion of Medi-Cal to adults who were previously ineligible, the feds for the first 3 years were paying the full tab. They're sort of phasing down now. We're going to end up at a 90% federal sharing ratio. That's terrific. That's pretty much unheard of. California, unless federal law changes, will pay no more than 10% ongoing for the cost of that optional expansion population. Some children in Medi-Cal are funded through the Children's Health Insurance Program. Back in 2013, all those kids, almost 1 million, were rolled into Medi-Cal, and now we take the CHIP dollars and pay for their services in Medi-Cal. For a long time, California was paying 35% of the cost, about a third, 35%. Yeah, okay. Then, with the Affordable Care Act, the Fed said, you know what, we're going to cut you guys a break. You can pay 12%, and we'll pay 88%. And of course, California and other states said, great, we'll take it. It's a wonderful deal. We're providing the same services to kids. It's just we're paying about a dime on the dollar, and you're paying about 90 cents on the dollar. That is terrific. So higher federal cost sharing brings more federal dollars in to support our Medi-Cal program. We've also had some creative financing where we've used provider fees, we've used healthcare taxes to find ways to bring more federal dollars into our Medi-Cal program in a way that increases or at least maintains services but doesn't impact the general fund. Why do we care about the general fund? We care about it because the general fund is basically the main source through which California primarily funds all the public services that we care about, whether it's the University of California, whether it's subsidized child care for working families, right? If it's our K-12 school system, that's pretty much where the dollars are coming from. And those dollars are always limited, right? The pie is limited, always. So the question is, how can you provide a robust Medi-Cal program that delivers the services that Californians need while at the same time preventing the Medi-Cal share of the general fund budget from getting larger? Because if dollars are finite, the more that go to Medi-Cal, the fewer dollars are available for our schools, right, for child care, for cash assistance for low-income working families. So there's always a balance, and legislators and past governors have always been concerned about this. Thank you. Okay, so that's sort of the deep background on how we got to where we are, maybe hopefully enlightening you a little bit in terms of how is this possible? How can we have such a robust program but have such little in the way of additional general fund spending? So we do have a few issues going forward, right? Some issues on the horizon, and Deborah earlier had 2 buckets. I'm going to give you 3 buckets, okay? So the first bucket is some changes to those cost-sharing ratios that I told you about earlier. The second bucket is always the possibility of a recession, right? Governor Brown always liked to warn about an impending recession. It will come someday. We don't know when. And the third bucket is some financing approaches that Deborah and others have talked about that are soon to expire. These are all concerns for Medi-Cal when you look at it from a financing perspective. So just first with the cost-sharing aspect of it, within the next year or so, we're going to be seeing federal costs, or the state share of the adult expansion population going from 7% to 10%. So earlier I told you eventually we're going to get to a 10% share of cost. We're going to get there. Next year we'll be there, and hopefully the feds will keep that in place for a long time. But those are real dollars. That means California will be paying a little bit more next year and ongoing than we've been paying the last year, 2 or 3, to support this expansion. Within the CHIP-funded population, that great deal the feds were giving us where they said, hey, we'll pay 88% and you pay 12%, that's going to go away over the next couple of years. Soon we'll be back to our historic sharing ratio where we will be paying 35% and the feds will be paying 65%. The services to those kids aren't going to change. They may get better for one reason or another, but basically we're just going to maintain the services. The state will pay more and the feds will pay less. That means a little bit more out of our general fund to support those kids. The recession. We don't know when it's going to come, but of course it will at some point. We're going to be in a better position, at least from a state level perspective, than we were 10 years ago because California's leaders have done a great deal to build up serious reserves that we can draw on when revenues fall during the next recession. We have a constitutional reserve that has over $15 billion in it. And actually, as part of this year's budget deal, the legislature and the governor created a new reserve. It's a discretionary reserve called the Safety Net Reserve. It only has a couple $100 million in it now, but it's intended for Medi-Cal and for CalWorks as a way of recognizing that during recessions, There's a sort of counter-cyclical effect where people start to lose their jobs. That means they're more likely to seek cash assistance through CalWORKs and health care through Medi-Cal. We have to find ways to bring those people into the program and provide the services they need. The reserves that we've built up provide a way of doing that. Those are reserves that we did not have when we fell into the Great Recession a decade ago. What about the feds, right? They were very helpful. The Democratic-led Congress, President Obama provided billions of dollars to prevent cuts to Medicaid across the country, including to our Medi-Cal program. Will that happen under the current administration if we go into a recession? That is a big unknown, but there are a lot of very pessimistic scenarios out there about what may or may not be coming in terms of help from the federal government when the next recession hits. Last point I want to make is on these expiring financing approaches. We've already heard a bit about the 1915B Specialty Mental Health Services waiver, which expires in July next year. We've heard about the 1115 waiver, that gigantic Medi-Cal 2020 waiver that expires at the end of 2020. One thing we haven't heard about is the MCO tax, right? The tax on managed care organizations, their Medi-Cal and non-Medi-Cal lines of business. If you've ever seen a Rube Goldberg scheme, this is kind of what that looks like. The end result of it is we draw down more federal dollars for our Medi-Cal program. The health insurance industry comes out ahead, and California gains a general fund benefit of $1.5 billion. A big mystery in some ways of Governor Newsom's budget proposal is that he is assuming that that tax will expire on July 1st this year, and that $1.5 billion general fund benefit will go away. That means those dollars would sort of go back into Medi-Cal, sort of backfilling the loss of the federal dollars, and they would no longer be available for other purposes, including some potential expansions within Medi-Cal itself or other healthcare expansions that these dollars could pay for. So putting a new MCO tax right through, what does that require? It requires the state to negotiate with the feds. The Newsom administration has expressed some concern about whether those negotiations would somehow hinder our effort to renew our other big waivers that are on the table for next year. But I just wanted to share with you, in case you haven't already seen it, that the Legislative Analyst's Office, the nonpartisan advisors to our state legislature, are arguing that the administration has not provided a convincing rationale for not going ahead with the MCO tax. So I think that's one of those issues that's sort of been flying under the radar, but it's something that's really important for folks to keep in mind, especially recognizing that it may be difficult in the coming years to get out of our waivers some of the federal dollars that we've seen in the past, given the rule changes that we've heard about, and the potential of a recession means that we really need to do everything we can in California to ensure that we're both providing a robust Medi-Cal program for Californians who need it, and at the same time limiting that program's impact on the general fund so that we can ensure that we're supporting a broad range of services that promote positive health outcomes for Californians. So I'll end there. Thank you.
Thank you, Scott. Well, thank you, Scott and Lindy. We have about 5 or 10 minutes for questions. Again, we need you to speak into the microphone if you do have a question for the panel. And I will, as you're formulating your questions, Karen, right over here. I'll exercise moderator's prerogative again. Lindy, you touched on this a little bit, but one thing we often hear from the provider community is that the rates they receive for serving Medi-Cal beneficiaries are lower than what they receive from, or the reimbursement is lower than what they receive from Medicare and commercial insurance. Can you talk again, or maybe highlight the relationship between these budgetary decisions that are made and how that trickles down or how that impacts these rates?
Sure. So, I think one of the biggest challenges we have is as you look at the rates, the limited funds that we have available, and really when you're talking about they're paid less than Medicare, and you're really looking at those at the fee-for-service rate schedule. And part of the challenge that we have there is the rates, many of them have been in place for a significant period of time. And in order to go in, we've had, individuals that have said we should set all of the Medi-Cal rates at Medicare and that would solve all of the problems. Well, part of the challenge of that is, again, as we've talked about, the $99 billion that we're already spending is with those rates at the level that they are. If we were to raise even just the physician rates by themselves to Medicare rates, we would be looking at multiple billion dollar increases to the cost of the Medi-Cal program. And as we've talked about, limited general fund availability, other additional costs coming forward. And so it's a big challenge of how do you find those dollars to increase rates at that level. I think the other thing that folks need to be really cognizant of is when you're looking at the majority of our population is in the managed care program, and the managed care plans are not limited to that fee-for-service schedule, and most of the managed care plans are not paying the fee-for-service schedule. And so there are rates that are out there that are being paid for a majority of the population that are higher than the lower than Medicare rates. And so that's one other consideration as you're looking at that, is that we are in many of the managed care plans seeing those higher rates are being paid.
Please.
Yes, the Affordable Care Act mandated, I think, 10 different categories of service that were supposed to be included. Are those still in effect? Does Medi-Cal incorporate them?
The essential health benefits? Mm-hmm. Yes, so we still have the essential health benefits are still in place for all of our plans. Medi-Cal was already covering a majority of those.
Okay, thank you.
Mm-hmm.
Any other questions before we break for lunch? Folks are as enthusiastic about lunch as I am. Well, I'm also enthusiastic about Medi-Cal finance, and so I want to thank Lindy and Scott for taking the time this morning with us.